is important for them to get the kind of support they need. Speaking as a father of 3 children, 2 of whom have, had counseling support of their own, and they don't have congenital heart disease, I think it's really important to try to get professionals to help with this. I don't think most parents are equipped, certainly I'm not, capable of lending the kind of support that mental health or counseling professionals can give. I don't know what's available in Manitoba, but I did investigate it a little bit in British Columbia. I'll put it in the chat. And there's a couple of groups. One is this group, I guess, mission called Foundry. And Foundry in British Columbia, anyway, offers free and confidential health and wellness support specifically for youth aged 12 to 24 and their families. It's free and anybody can access it. I honestly don't know how good it is, but I have it on reasonable assurance that they do a pretty good job. And in fact, the province of British Columbia, through the Department of Child and Youth Mental Health, also offers support for kids 0 to 18 years of age at no cost. And their clinics are staffed by mental health clinicians, psychologists, and psychiatrists. So I think advocating for counseling support or mental health support through your cardiologists is an important thing to do for, I would say, most, if not all, of these children that are going to feel different than kids that haven't undergone all the things that they've undergone. Again, I don't know what's available in Manitoba. I know in British Columbia, we don't really have, at least up until the time I was practicing, didn't really have a unified place where these kids could get together. I know there's certain things put on by the Children's Heart Network, but certainly when I was in the States, they had things like heart camps where these kids could get together and bond with each other. And they were like heart camps for a week without parents. And I think that made a big difference for some of these kids that could identify with other children that had gone through the same things that they'd gone through. So I don't know how well that answers your question, Jen, but certainly if you have anything to add, I'm more than willing to hear it. You're muted.
Yeah, I know I'm on my cell phone, so it's a little trickier. I know we do have the heart camps as well here, and I'm trying to convince my kid to go this year. He did go to a teen event recently, so that's kind of helpful too. I kind of want to move back to BC for that free assessment and care there, because that's pretty impressive. It is hard to come by counselors right now in Manitoba, and nothing free that I've come across aside from like in school, like guidance counselor kind of level. But for some of these issues, it even kind of extends past what their capabilities are. So yeah, I'm going to keep hunting. If anyone else is from Manitoba, I can let me know if you know places.
Yeah, I don't see a problem, especially since you have some ties to British Columbia, of trying to access some of these things like Foundry and see what they say. Maybe they won't notice your postal code. Like, who knows? See what happens.
I had thought that too, so I might actually give it a try.
The next question, and I don't know if anybody here asked it, but it had to do with surgical techniques or procedures on the horizon that promise a better quality of life for complex heart patients. And there was another question particularly concerning the Fontan procedure and its associated risks like liver disease. So I thought to answer this, it'd be nice to provide a little perspective. I know I did a little bit last time when we were talking about single ventricles, but there has been a lot of advancement over the last 3 or 4 decades in terms of congenital heart disease treatment, diagnosis in general. So first of all, start at the beginning. I mean, nowadays, the vast majority of these children, with the exception of a couple diagnoses, should get diagnosed at the 20-week ultrasound. Fetal diagnosis should be the norm, not the exception. And if it's missed, that's either 1 or 2 specific diagnoses that are very difficult to make in utero, or it was just missed. And so that's something at the start that's way different than it used to be 20 or 30 years ago. And the other thing that's become very clear is that some of these kids, not all of them, but some of them are subject to developmental issues, brain injury before or after their procedures as babies. And I think clinicians have become much more attuned to that. in trying to diagnose it and to treat it proactively so that it limits the effect of brain injury on development as time goes on. And then when it comes to taking care of these kids, we've made big leaps and bounds really in the prenatal care, in the care of these babies before they go to the operating room if they need an operation or a procedure early on. We did all kinds of crazy stuff even in the early 90s that we don't do anymore because we've realized that Mother Nature generally does a better job than doctors do in a lot of things. We have postnatal diagnostics that are far superior to what they used to be in terms of three-dimensional imaging, 3D printing, MRIs, the way CAT scans are, 3D echo machines, all that sort of stuff, which is far better than it used to be, giving us a much better roadmap of what we're going to do. And now it's not just about surgery, although surgery is the mainstay for most of these kids. The interventional cardiologist can do a lot in the cath lab. Sometimes they can temporize things. Sometimes the procedure can be what's called a hybrid procedure, where part of it's done in the cath lab, part of it's done in the operating room to reduce morbidity. And certainly we understand a lot more about taking care of these kids after their operation than we used to. With the Fontan specifically, again, Fontans used to be like these major ordeals where we knew the kids were going to be sick as hell for a few days, and that's just not the case anymore. And really that has to do with our much better understanding of the physiology of that circulation and how best to care for it afterwards. So I think all of those things have contributed to a much decreased mortality for sure. And I think a significantly decreased morbidity or complication rate for a lot of these things compared to how they used to be. As far as Fontan failure goes, that's still a bit of a black box. I mean, there's a lot of obvious things that cause Fontan failure, but there's a lot of things that are not that obvious that cause Fontan failure also that we really don't have a good handle on. But I think clinicians, again, are better than they used to be in terms of picking up on it earlier to hopefully mitigate against further complications down the line. There has been a fair bit of interest in this topic, especially when the single ventricle, especially with regards to the single ventricle kids. In I think 2018 and 2019, there was a single ventricle summit held at Stanford University in San Francisco, where there was a group of basic scientists and bioengineers and clinicians from across the planet, really, that came together to try to figure out things that we need to focus more attention on with respect to kids born with single ventricles, and to try to develop techniques or investigations that expanded our knowledge base on these kids. It had to do with arrhythmias, it had to do with developmental biology, it had to do with the development of their pulmonary blood vessels and their lymphatics, and with blood clotting in these kids, and certainly with supportive things like machines, mechanical support later on. So a lot of those things are being worked on. I can't tell you that there's like dramatic improvement in any of them, because I'm looking with a different lens than one would look if they're looking 20 years ago versus now. But I think if you look in the next decade, there will be significant improvements for these kids. Won't necessarily change the course for your children, but it might change how they're managed proactively in terms of, again, trying to prevent complications. So hopefully, Jackie, that was your question. Hopefully that answered some of that, but there's similar questions later on too that I can go into with regards to that. Is there any follow-up or further questions you had about that, Jackie? You're on mute too.
Yeah, so I've been following an Instagram group, and I think there's a doctor in the States that's looking at a heart pump that is almost a replacement of the Fontan, or works in conjunction with the Fontan. Do you know what I'm talking about?
Yeah, well, there's a couple. Do you know the guy's name?
I don't remember it off the top of my head. I haven't seen any posts from them for a while. They've been quite a bit quiet, so I don't know off the top of my head, but yeah.
Do you remember where they were from? Were they from Indianapolis?
I think it might have been.
Yeah. So
It helps to regulate the blood flow, so I think that there's less leakage or something.
yeah, so well, I can speak specifically to the guy from Indianapolis. His name is Rodefeld, and I actually worked with him.
Yes, that's it. Yes, yes, yes,
Yeah.
yes. Thank you.
So his name is Mark Rodefeld. I actually was a resident with him in the lab way back when. And so I've kept in touch with him over the years. And so Mark's been working on this pump. It's not a replacement, but it's an augmentation for kids with single ventricle. So it's like a rotary pump that goes in the circulation that sort of sits there in suspended animation and increases blood flow, so to speak, or it makes it more efficient in the right-sided circulation where there is no pump, because the right ventricle is eliminated from the Fontan circulation. Whatever ventricle the kid has is pumping blood to the body. So the last time I spoke to him about this was a few years ago, and he was hopeful that it was going to come up for human trials and FDA approval and all that sort of stuff. But it's obviously a slow process because he's been working on that for at least 15 years, if not longer. But I still think it probably has some promise in the future. And a lot of the problems that these kids get are secondary to the fact that the circulation on the right side is all passive. The blood's just getting to the lungs because of gravity and nothing else, and you don't have a pump helping it. So if there was a way to implant a pump in the circulation to help that blood flow, theoretically that should help a lot of the problems that kids with Fontan circulations get down the line. The obvious issue is putting an artificial device in carries its own set of problems, like blood clotting and infection and all that sort of stuff that any artificial device has. So I think it's still a work in progress, but it's something to look forward to in the future.
Yeah, thank you. Our daughter was to have the Fontan, but she's 7 now and has escaped it, and we're grateful for that. It's her right ventricle that's underdeveloped. Anyway, so that's where my question is coming from.
Does she have pulmonary atresia or something?
Yeah, pulmonary atresia with intact ventricular septum.
Yeah.
She's had the Glen, and it's worked well for her up till 7 years old. We don't know if she'll need the Fontan if she hasn't had it already, but as you know, you don't know until you know.
Yeah. Well, I mean, pulmonary atresia intact septum is, again, one of those ones where there's a whole spectrum of things that can happen. You can either go down the Fontan route in the extreme situation, you can go down a biventricular repair when the right ventricle is developed enough, or you can be in that sort of middle ground where you get by with a 1.5 ventricle repair where the ASD is left open. And that's probably a better scenario.
Yeah.
In fact, it is a better scenario than having to go down the Fontan route. It still leads one to worry about what is there in the place of a pulmonary valve, because those kids don't have a pulmonary valve. So for a lot of them, they get a patch on the right ventricular outflow tract, so they have no pulmonary valve, which is fine for many years. But ultimately, they probably would be better off with the pulmonary valve, which sets you down another pathway of requiring pulmonary valves as time goes on. But I think that's probably a better pathway to be in than a Fontan pathway if you had to choose. Nobody really knows the answer to that question because all this stuff is relatively new. But like if I was choosing, I would probably pick that pathway versus the Fontan pathway in general.
Very helpful. Thank you.
You're welcome. Jessica says, what are your thoughts on bioengineered cardiac tissue from stem cells? Well, that was actually, I was going to talk about that as another question, but I can talk about it now. I think could it eventually be used in early stage heart failure to prevent it from getting worse? The answer is yes. I think it's very promising, the stem cell research that's going on, and it's already been employed in a variety of disciplines in cardiac surgery, even in adults that have had heart attacks or myocardial infarctions that have lost part of their heart function, and stem cell research is being investigated in those areas to regenerate myocardial or heart function. And certainly if it was done earlier in children, it does have the potential of improving heart function or regenerating cardiac tissue where that cardiac tissue is absent. Again, that's more of a long-term speculation. I know there are trials ongoing, and hopefully we'll get those answers in the next decade or so, maybe sooner. I don't know, but I think a lot of that stuff is promising. There's a lot of bioengineering stuff in general that I think is promising. It was in the news yesterday or today, maybe, about another xenotransplant with a pig heart into a human, and that pig heart wasn't just a heart from a pig; it was a bioengineered pig heart. So I think a lot of that stuff is very promising. There's a lot of steps to go through, especially with different species, but the things they can do with DNA now are quite remarkable. So, I think if we were having this talk in another couple of decades, I think it would be very, very different what's available for a lot of these kids and the treatment potentials that are available. So all of that stuff, and stem cell research is sort of like bioengineering to some extent. So I think all that stuff carries potential for these kids. And if your kids are young enough, then who knows, it might be, there might be possible therapies in there in the future.
Dr. Gandhi, can I ask one question on, I don't know if this is related, but the term angiogenesis has come up recently with our stuff. Is that related to this, or can you comment on that in any way?
Well, angiogenesis has to do with the growth of blood vessels. So that's a little bit different than myocytes, which are the cells that make up the muscle of the heart. And a lot of these single ventricle kids need more heart muscle wherever it's missing. Angiogenesis is related to either the veins or the arteries that connect to the heart, often within the lungs themselves. And there are research studies going on with things like angiogenesis growth factors that help blood vessels grow. So that's, again, an area of expanding laboratory research. How much will be applicable to the human population clinically in a short period of time is, like, I don't know the answer to that question, but people have been looking at that for a while. So, again, hopefully we have answers to that sometime in the next couple of decades, but I don't really know how quickly that's going to come about. But that's what angiogenesis means.
Appreciate it. Thank you.
Okay. The next one has to do with longevity and quality of life. What's the expected quality of life and longevity for someone living with half a heart, like those with single ventricle conditions or post-heart transplant? So those are very different things. But again, if you want to talk about single ventricle, the answer I can give you is that, well, first of all, the first Fontan operation was performed in the late 1960s. There was a 40-year follow-up study of Fontan's done. I think it came out of the Mayo Clinic, and it was published around 2015, 2016. And it demonstrated a 30-year survival rate that at that time was over 40%. And you're thinking, oh, 40%, that means 60% of kids didn't survive 30 years. But most of those kids had the original form of the Fontan operation called the atriopulmonary connection. So it's quite a dated operation. And even with that dated operation, almost half of them survived 30 years, which, for single ventricles being born in the 1970s, basically, that was pretty impressive survival. I can tell you with the newer iterations of the Fontan operation, the 10 and 20-year survival rate in a lot of studies exceeds 90%. So I don't know what that's going to translate out to 20, 30, 40 years down the road, but I can't imagine it won't be significantly better. Right now, there's estimated to be between 70 and 100,000 patients worldwide that are alive with the Fontan circulation. So it's a growing population of individuals. And about half of them, like we said in one of these sessions, half of them are adults. So there's an enormous number of these patients that have survived, whereas decades ago they didn't. So I think it's hard to know how long they're going to live. And as far as quality of life, that depends on a lot of things. I think the quality of life is not just dependent on their circulation. Of course, that's very important, but it Also depends on what other medical issues they have, what other comorbidities they have, what other problems they have, both in their heart and outside of it, to determine what kind of life they can live. But like I said before, I don't think it's ever wise to limit these children. I think they should do what they can do, and they're going to limit themselves. As far as heart transplantation goes, in kids, that started in the 1980s, so our data is even, we have less follow-up data on those kids, but many of them have survived 20 or almost 30 years with the same heart. Not all of them. Many have needed repeat heart transplants, and some of them haven't survived, of course. But the follow-up data for heart transplants in young children is quite good. And the last time I did a head-to-head comparison, it was better than the Fontans for the length of follow-up that we had at the time, which is probably 7 or 8 years ago now. So again, I can't imagine that's not going to improve with the way we've advanced medical therapy for heart transplant patients, but that remains to be seen. Of course, the problem with heart transplants is getting the donor organs. Fontans, you don't have to get anything for them. You just have to use pieces and put them in. But heart transplants, you of course need a complete limiting step. So surgical decisions and considerations for sort of the next group of questions. Some of these are we've sort of gone over already, but just for the sake of being complete. Jessica says, would a heart transplant be possible for left-sided heart with left-sided IVC and SVC, and a liver transplant for a midline liver? Yes, yes, and yes. So we can transplant anything into anything. It doesn't matter what the recipient or the person that needs the heart, what their anatomy is. And a left-sided IVC or a left-sided SVC is pretty easy to deal with, technically speaking. Liver transplant for a midline liver is not an issue at all. And so some of these kids have all kinds of crazy anatomy, but we have techniques for all of that stuff. Like I've transplanted all sorts of normal hearts into very abnormal chests. It does take some effort and some knowledge. So like I wouldn't trust an adult heart transplant surgeon to do it. So if your kids be of adult age, that's why congenital heart surgeons sort of need to be involved with all that stuff. Like I wouldn't think twice about left-sided SVC and IVC, but if you had an adult heart surgeon do it, they won't see that kind of stuff routinely. So they'll think more than twice about that kind of stuff. So that's why that special expertise is necessary. Okay, so the first question in the next section was, how do you decide between repair versus Fontan for complex congenital heart defects? And again, I talked about this a little bit on the last session, but that's a very complex question based on the specific anatomy of the child. But the most important thing to know is that there's not a right answer here, and that the natural assumption that a 2-ventricle circulation at the end of the day, that means a repair, is better than a Fontan, is not always the correct assumption. Sometimes you stretch that 2-ventricle repair such that you leave children with a borderline 2-ventricle situation, and that doesn't do anybody any favors. It's much better to have a good 1-ventricle repair than a borderline 2-ventricle repair. I've seen a lot more problems with the latter than the former, understanding that the Fontan is a setup for all sorts of problems down the line, but still a borderline 2-ventricle circulation is a setup for all sorts of problems starting very early on. And a lot of those kids have issues. So I think it's really important to make that assessment based on the specific anatomy and physiology of the kid, but not let the decision be swayed by the fact that 2 is always better than 1. And the leaving conditions like an ASD is a pop-off, much like Jackie's kid might have. I don't know if she still has an ASD. The only problem with an ASD as a pop-off is that there's a connection between the left and the right side of the heart. And so when you have a Fontan without a fenestration or a fenestration that's been closed, the left side of the heart and the right side of the heart are separate, just like our circulations are. The blood on the right side goes to the lungs, and the only way it gets to the left side of the heart is after it gets filtered through the lungs. But if there's a connection, that means blood can go from one side to the other. And in theory, that means that stuff on the right side can get to the left side without getting filtered to the lungs. And that stuff that I'm talking about is like little micro blood clots. And we all have micro blood clots in our system. Some people have them more than others. Specifically, women have them more than men. Pregnant women have them the most. Sedentary people have them more than unsedentary people. And any of those blood clots that can go from the right to the left can fly off to wherever they want. And the most dangerous place for them to fly off is to the brain, causing stroke. So there's a higher incidence of stroke in children that have a connection between the right and the left part of the circulations, like an ASD that's left untreated as a pop-off valve. But sometimes that pop-off valve is much more important for other reasons. So the pros and cons of having it far favor having it versus closing it. And the next question had to do with, it said, for a child initially deemed infeasible for a Fontan due to anatomical constraints, is pursuing a Fontan after preliminary procedures advisable? And what comparisons can be made with children originally feasible for the Fontan? Well, honestly, if the Fontan's being delayed due to anatomy, that's a prudent thing to do. You don't ever want to rush into a Fontan in a subpar situation. But also, honestly, if that's happening, the kid's candidacy for a Fontan is not as good as it would be if you were able to do it right off the bat. That doesn't mean that there aren't some kids that can still undergo a very successful Fontan. I've done that several times where you've had to wait for pulmonary artery growth or this problem or that problem to be resolved, or an extra operation even is involved sometimes to fix something unexpected in the heart, and then they get a Fontan later on and they do just fine. Like I have kids that are 10, 15, 20 years out from that pathway that are still just fine. But it always introduces the possibility of higher risks and makes you worry a little bit more. Doesn't mean it can't happen, but it does make you worry a little bit. The next question had to do with, and I don't see her name here because I think I know this mom, but managing hemolysis from valve replacement. And so that's if your kid has an artificial heart valve, and then they have this thing called hemolysis. Hemolysis, for those of you that don't know, means that the body chews up its own blood cells, specifically the red blood cells, and causes the blood count to drop, or kids become anemic from the heart chewing up blood. That can happen in a variety of situations in congenital heart disease. It most commonly happens with artificial valves when there's a little leak around the valve, but it can also happen anytime there's a patch inside the heart and there's a little leak around the patch, or anytime there's any prosthetic material in the heart and it starts to deteriorate like a heart valve. And in those situations, though the hemolysis can be managed temporarily medically, it's almost always the circumstance that repeat surgery is necessary. So if there's hemolysis from a valve replacement, most of the time that means there's a leak around the valve. It's called a perivalvular leak. And unless that leak seals, and it can seal if it's early on, but usually if it's later on, it doesn't seal, then the treatment for that is to fix the leak. Now, sometimes if the valve is still functioning well, a perivalvular leak can be fixed in the cath lab. They can put a little device in and seal the leak. But if the valve's not working well or it's deteriorated, then the treatment of choice is to replace the valve, which fixes the leak at the same time. There was another question about if my kid has a pulmonary valve stent, is that going to affect his or her candidacy for a heart transplant later on? And the answer is no. So anything that's done to the heart inside the heart won't affect candidacy for a heart transplant because it's all going to get cut out anyway. So there are some things that can affect candidacy for a heart transplant, but most of them, like I answered with Jessica's question earlier, can be dealt with. But certainly any prosthetic material inside the heart is, including stents, valves, whatever, patches, all that stuff's irrelevant because it all gets cut out and put in a bucket anyway, and the new heart gets replaced, gets put in there and replaces all that stuff. We've talked about research for single ventricle patients, which is the next question. There was a question that had to do with double and left ventricle, but it's really a broader answer. It had to do with genetic links and the possibility of recurrence in siblings. So that's a good question that I think most moms are curious about when they've had a kid with congenital heart disease. So as I'm sure you all know, the incidence of congenital heart disease is about 1 in 100. It's 9 to 11 per 1,000 live births. So 1 in 100 kids is born with congenital heart disease. That means 99 out of 100 kids are not born with congenital heart disease. But if you've had a kid with congenital heart disease, the chances of you having another one goes up. It goes up 4 times. So if you're looking at the glass half full, that means next pregnancy, 96% of the time, you're going to have a baby with a normal heart. But 4% of the time, you're going to have a baby with congenital heart disease, which is very low, but still 4 times more likely than if you didn't have a prior kid with congenital heart disease. Now, I've seen it rarely where it's the same diagnosis, like a mom has 2 kids with truncus arteriosus or 2 kids with hypoplastic left heart syndrome. I've frankly seen it more commonly where it's a different diagnosis. So baby A has one congenital heart problem and baby B has a different congenital heart problem. So there's got to be genetics involved. I don't think we don't have the capability to know the specific genetics in most of these circumstances. There are genetic links known for congenital heart disease, the obvious ones like Down syndrome and syndromes that cause specific heart defects are well known to everybody. But there are also genetic links in things like coarctation of the aorta. There are certain genes that have been implicated in hypoplastic left heart syndrome. I mean, I've seen a dad, a son, and a grandfather, all that had coarctation of the aorta. So there's obviously some, and all the girls in the family were spared. So there's some sort of male genetic problem in that family. And I'm sure there are genetic problems in a lot of families. We just haven't identified them. And that's why most congenital heart disease is what we call de novo. So it's nobody's had a history of it before. There's no family history. There's no sibling history. There's nothing. Just you have a kid with congenital heart disease. But anyway, the stats are that your likelihood is 4 times more if you've had a previous kid. And that's why we recommend that in subsequent pregnancies, in addition to the routine 20-week ultrasound, you also get a specific cardiac ultrasound at that time to make sure nothing's missed. It might not change anything for you, but it might, especially if the kid has a heart defect in terms of management in the early neonatal period.
Can I add one thing to that? Because we had a second child after our child was born with congenital heart disease, and I believe in BC we were allowed to get extra testing done as well. I might be wrong because there was just a lot going on at that period, but I believe they actually enabled us, like during that additional pregnancy, to get subsequent testing, additional testing, whether it was genetic or otherwise. So at least that's available in BC from what I remember. I'm not sure what other places, but.
Yeah, I'm sure that's true. Have you noticed more incidents of congenital heart disease with twins? You're not going to like what I have to say about this, but I hate congenital heart disease in twins because all the twins that I've dealt with congenital heart disease, it just seems like the twin that has the heart problem. Like I've never seen twins except for conjoined twins, which is obviously crazy rare. I've never seen twins in which both of them have had a congenital heart problem if they're not conjoined. And the ones that have the heart disease tend to be, it might just be anecdotal, like, because, and I can certainly remember them, have been far sicker than they should have been given their diagnosis. But it's interesting how many times I've seen congenital heart disease in twins, both identical twins and non-identical twins, and it's always just one kid has the heart problem, the other kid's normal. It happens so much. There's obviously a genetic basis behind all of that, but I'm not smart enough to know the answer to that question. Oftentimes, though, especially even if it's complex, like if the operation goes fine, like you can't tell the difference later on, right? Like I have a couple mothers that send me patients of their twins that have through the years where it's really difficult to tell like who's the heart kid and who's not the heart kid, which is reassuring. How can parents best prepare for a new baby with a condition like hypoplastic left heart syndrome, including, I think this question had to do with this, including exclusively breastfeeding and prenatal care to ensure a healthy pregnancy? Are there general recommendations or specific prenatal vitamins to consider? Well, first of all, by the time you know that your kid has congenital heart disease, it's fait accompli. The heart development's done by the mid 20-week point. So if the heart's not going to develop right, there's nothing you can do. And cardiac development starts very early at week 5 or 6, so before you know you're even pregnant. So there's not anything you can do prophylactically, vitamins or otherwise, to prevent what's going to happen. Having said that, I mean, there are certain things, certain drugs that have been implicated in contributing to congenital heart disease. The evidence is sometimes strong, but there's never been a direct correlation between a specific drug and a specific diagnosis. Nonetheless, so there's no specific vitamins you can take or drugs you can take to make it better after the diagnosis of congenital heart disease has already been attributed to your fetus. Now, the other question is very good. Like, how do we take care of them after they're born? And most of the time, unless they need something done like urgently within the first day or two of life, which is very, very unusual, these kids should be cared for like any other kid. Specifically with breastfeeding, like I was the biggest promoter of breastfeeding because I think it's the best way to care for these kids. It gives them the antibodies of the mother. It increases maternal child bonding. It's the best form of nutrition. And I think you just need to push for it if the doctors are reticent to do it. And the times that they would be reticent are hypoplastic left heart syndrome. That's a very controversial one in the sense that there are some institutions that still don't feed their kids, and some institutions feed them through intravenous lines and things like that. And I think all of that, like, not to mince words, is hogwash. So I think the best way to feed those kids is to breastfeed them. And when I was doing this, I just said, not only breastfeed them, but exclusively breastfeed them. So I didn't let them drink from a bottle. I didn't even let them drink breast milk from a bottle because it's easy to force feed a kid from a bottle. Like you can get whoever is feeding the kid trying to get the kid to eat and push. And that can lead to problems like things like necrotizing enterocolitis, which is sort of an infection of the gut, which can be a life-threatening problem, especially preoperatively. But very rarely, if ever, do kids push themselves to that. They will regulate themselves. That's when I said Mother Nature does a better job than we do. Kids understand when they're hungry and when they're not. And if they don't eat a lot in the first few days of life, fine. They don't eat a lot in the first few days of life. But I think it's important for them to get used to it, because kids that have at least had a chance to eat before their operation or breastfeed before their operation do far better after their operation than kids that haven't had a chance. And frankly, if the operation goes well as a baby, a lot of the post-operative stay is, okay, getting them to eat, getting them to gain weight before you can send them home. And if they've already had a head start on that, that's why the length of stay at BC Children's when I was there was so short for babies, because they tended to eat really well after their operation, and then they go home. They eat, they go home. So I'm all in favor of that. And I don't think there's any contraindications to breastfeeding just about any kid with congenital heart disease before their operation, including kids with hypoplastic left heart syndrome. The next question, how can parents, this has to do with the healthcare system, how can parents access and advocate for the best possible care and top surgeons for their child, both within Canada and internationally, while maintaining respect and efficacy in their advocacy efforts? Well, that's a really good question, and it's a difficult one. I think congenital heart surgeons are fewer in number than just about any other surgeon on the planet. I don't know how many there are in Canada now. When I left a year and a half ago, there were, I think, 13 and a half of us nationwide, 13.5 congenital heart surgeon FTEs from coast to coast. So it's not like you have a huge pick. And in the United States, there's obviously more, but still, from a population standpoint, it's not a ton more. So I think the most important thing is to assess what you're getting. And part of that's going to be just meeting the guy or gal that's doing the operation and the team that's going to be taking care of your kid and trying to figure out if you gel with them and if you bond with them. I mean, being a surgeon, obviously the biggest part of it's the cutting and the sewing and the fixing the heart part of it. And they have to be competent in all of that. And you have to be able to ask probing questions in terms of experience and results and try to gauge whether or not the person that's taking your child to the operating room has the capability and the expertise to fix what needs to be fixed. Part of it has to do with just the human interaction, something that you'll either get or you won't get when you meet this person, in terms of, is this person someone I can trust to take care of my child? And, you know, trying to, I don't know how parents do it nowadays. If it's on social media, I try to stay off that stuff, but trying to gauge the competency of your team is probably the most important thing to do. The grass is not always greener on the other side. Just because it's a famous institution somewhere doesn't mean you're going to get better surgical care or better care in general. Just because they have a name and they can advertise better and their pamphlets are color and they advertise better, that doesn't necessarily mean you're going to get better care, especially if it's south of the border, because they're in the business of trying to attract patients. So I think it's just really important to try to get an assessment as best you can as to the capabilities of this team. I'm more than happy to help anytime. Like I still know most of these people, and I'm not shy about telling you if the answer is right or wrong in terms of who you should go to. Is there a lot of difference in surgeon to parent contact post-surgery in different surgeons? Oh yeah. Yeah, like a ton. So like a world of difference. So there's some surgeons that adopt what I call the dump and run model, which is, my job is to fix your kid's heart and then see you later. Like everything else is the responsibility of someone else. That's one model. And then there's a completely diametrically opposite model where the surgeon is involved in every aspect of care from beginning to end, which tends to piss a lot of people off, but I didn't really care. That was sort of my model, that I wanted to know everything about everything from start to finish. And the reason for that isn't just a control freak thing. Yes, I'll admit the control freak part of it, but it's also because I really think that when it comes to postoperative issues and complications, most of the time you don't have any. But when you have them, like in a kid like Jen's kid, it's the surgeon that's going to recognize them or know the basis of them, because almost all of the stuff that happens postoperatively can be traced to what happened in the operating room. It's not a malevolent thing or a malicious thing. Like, we don't intend for complications to happen, but we know that stuff we do causes complications, whether it's arrhythmias or fluid collections or valve misfunction or whatever it is. Like, stuff that we do leads to problems postoperatively. And so we're best suited to identify those problems and help fix them, which is why personally I think that surgeons need to be actively involved in the postoperative care, which is why I never did an operation on a complex operation on a kid if I knew I was going to be out of town 2 or 3 days later, because I didn't want to just leave the kid there without surgical support. But I'll admit to you that that's not the predominant model of care. So the predominant model of care probably is somewhere in between those two extremes, where, I'm available if you need me, but try not to need me, kind of thing. So yes, there is a difference, and I've seen all different spectrums of postoperative care when it comes to surgeons. And I think it's, like, I hate to say this, but I think it's evolved, let me say, over the years. So it's evolved to less postoperative involvement from surgeons compared to the way it was when I started. I think there's also a difference when it comes to the 49th parallel. Like there's a difference north of the border and south of the border too. Okay, that 7:55, that finishes the list of pre-asked questions, but I'm happy to expand or answer anything additional that anybody has.
I'd have maybe more just a comment. I don't know if you're planning on doing more of these or not, but like when I was signing up too, sometimes it's hard to think of questions, but I find even like every time I've come to one of these, other people's questions have been really helpful information to kind of glean from as well, things that I maybe hadn't thought of or whatever. So just like in my thoughts of with you prepping for another one potentially of maybe giving freedom for people to join if they don't have a question. I'm not sure, but
Yeah, and hopefully we've made that clear, but certainly we want everybody to join. And there were a bunch of people, like, again, we only had 10 log in tonight, but there were 20 something that signed up, and a lot of them were, I just want to listen in. So, but we'll make that, it's a good point, we'll make that really clear to people. Tony also had an idea about some guests that we could have on too. So we have to try to find a way to, and yes, the answer is we're going to do more of these, try to find a way to expand it to an even larger group. And again, I think you guys will be better certainly than I will at that in terms of your social media connections and trying to get it out there. And it doesn't have to be limited to Canada or Western Canada or whatever, like whoever. And I'm sure a lot of your groups infiltrate south of the border and wherever into the United States. And there's, I think if parents, especially in the US, knew that they could have this kind of free access, then there would be a lot of interest. It's just a matter of reaching out to them and crossing time zones and things like that.
So are you saying we can encourage through our other, like I have social networks of heart moms to attend your these
Oh,
sessions?
of course.
And
Everybody, like everybody's invited.
and how often, like I only just found out about this one a couple of days ago, but it sounds like you've had them before. Are they regular? Are they
Well,
only...
we started this, when the first one, Tony, was in February?
We did February 7th, February 27th, and March 21st so far.
Yeah.
So this is our third one.
So this is our third one, yeah.
And we can
And
attend more than once, can we? Because there's
yeah, of course. You can attend it. Some people have attended every one, and some people have attended selected ones. The last time we had like close to 30 people. The first time we had probably close to 35 people. And so, yeah, and there's no, the second one, I specifically said we would talk about single ventricle kids because there seemed to be a lot of interest in that. But the first one and this one, there's been no specific topic. It's really just a forum to be able to access somebody that knows a little bit of something about heart surgery and feels like he still wants to contribute.
Thank you.
And so, like, I'm happy to talk to anybody. And, as this evolves, I'll find a way to be able to connect with people one-on-one. Like, Jackie, you might have specific questions about your kid and you might want to just talk to me alone for 15 minutes. Like, that's fine. So obviously I'd need more information about specific things about your kid if I was going to do that. But again, it's just, I know getting information in this space is difficult at times, and approaching healthcare professionals is difficult at times. Everybody's rushed. Nobody has time to answer questions. Oftentimes parents don't get the time they deserve. And frankly, sometimes stuff is sugar coated. And if I've learned one thing over the years is that the vast majority of parents just want the truth. They don't want sugarcoating. Like, they just don't want everything's going to be fine. If it's going to be fine, great, fantastic. But if it's not going to be fine, or if there's a potential it's not going to be fine, then they want to hear that too. They just want the truth. And sometimes that's difficult to elicit from healthcare professionals. Sometimes it's not. Like, a lot of people will tell you the truth, but I think parents are always seeking information, and these days, you know, if you, again, I try to stay off all this social media stuff as much as possible, but I'm not even part of Facebook or anything like that, but from what I've heard, like some of the forums are great, and some of them you can get whatever answer you want, or there's 15 parents and they're all MDs on there, and they all give you different perspectives based on their kid. And the problem with congenital heart disease is that every kid, the nuances of every kid are different, and so you can't generalize an answer for the whole population of kids.
Right.
Just because one kid has pulmonary atresia impact septum, it's not going to be at all like the next 10 that have pulmonary atresia impact septum. So that's why I think it's helpful sometimes to eliminate Dr. Google and just, you know, go to somebody that can talk to you face to face.
But I want to just sincerely thank you for this opportunity, because, and I feel quite emotional. I've been in this journey for 7 years and I have received information, but this hour has been dedicated to, as you say, the truth and the black and white information that through your experience. And it's been extremely helpful. Some things I don't want to hear, but I have to hear them, right? And I just, I will come back, and I appreciate you contributing your time to myself and other people on the call, and I'd be happy to listen in again. So thank you.
Sure,
so
yeah,
much.
and definitely reach out to your friend. Where are you from, Jackie?
I'm from Vancouver. I follow a Facebook page. Yes, I know social media, but it's parents, mamas of heart babies, and it's just the parents, and they talk about different diagnosis. And one lady's kid was completely blue, and their hospital, their cardiologist in the state said it has nothing to do with the kid's heart, and kept sending the kid home. So it's yeah. So it's parents who have their children, they have the different heart defects and they're just looking for support from other heart moms. And there's, as you say, there's the whole spectrum, and that's the one I kind of follow the most. And it's not doctor oriented or anything. And it seems like it's probably 75% US and maybe 25% Canadian people on there. But I'm from Vancouver.
Send out a message on that group if you want, and say, you know, the next one you can join, and
yeah.
And it'll be helpful. So how old is your child?
She's 7. London is 7. So she had her Glenn when she was 5.5 months old, and has zero complications. And
did I do it?
You were away. So it was the other Dr. Campbell that did it. Yeah. So it went well, and we just don't know. Like I said, you don't know until you know, but every day is a bit of a gift. So.
Yeah, well, again, you're more than welcome to share it to anybody. And Tony and I haven't discussed the next date, but we'll figure that out soon.
Okay.
Yeah, right. And to kind of echo on that, we're going to send out a feedback survey after this session. You guys will get it in shortly right now. Just if you have any feedback on the sessions, both in how we run it, but also ideas for additional sessions. We've talked about having some guests on. We referenced maybe potential one-on-one sessions, that type of thing. So please feel free to share that. I also shared the YouTube link in the chat. So please follow that. We'll post every single one of these up on YouTube. We'll also start sharing clips and stuff like that from the event that, you know, you can share on social media and sort of like, you know, attract other people to come to these things. And we'll share the next date fairly soon, but we've been doing it every 3-4 weeks, and I think we'll try to continue that cadence. So awesome. Okay. So I think we'll leave it there.
All right. Everybody have a good night.